So thank you so much for having me. I'll be talking about Meibomian gland dysfunction, and I'll be going through some of the current perspectives when it comes to diagnosis and management. So we know that over the last few years, there has been a considerable increase in the understanding that we have of dry eye, and that has led to a much greater scientific interest in the disease. What we also know now that about 60% of the patients that present to us with dry eye have Meibomian gland dysfunction. So they have dry eye secondary to Meibomian gland dysfunction, and about 10 to 15% have a mixed component. This is the vicious cycle of dry eye that has been described. Dr. Hitendra also spoke about hyperosmolarity, inflammation, tear film instability playing very important roles. So what is important here is that any of these etiological agents can lead an individual into this vicious cycle of dry eye, which then self-perpetuates and carries on even if you've removed the original agent that got the person into this cycle in the first place. And of course, Meibomian gland dysfunction is at the core of this. So in this cycle as well, you can see proliferation of bacteria in the flora of the eyelids and the conjunctiva, which produce lipases, esterases, and other digestive enzymes and fatty acids that increase the melting temperature of meibum. And that subsequently leads to the blockage of meibomian glands and further on to dropouts and atrophy of these glands. And inflammation also plays an important role, which leads to keratinization of meibomian gland orifices, again leading to the same outcomes. This is what leads to an unstable lipid layer, subsequently translating into too much evaporation of tears from the ocular surface, leading to a dry cornea and subsequently dry eye. So when we're evaluating a patient with Meibomian gland dysfunction or with any form of dry eye for that matter, it's always best to start from the most non-invasive investigation to the most invasive one, because each investigation that you do subsequently has an impact on the next one. An important tool that I like to use in my practice is the OSDI questionnaire. There are a lot of other questionnaires available as well, and they're validated and equally good, so you can use those as well. The important thing with questionnaires is that you're able to document how symptomatic the patient is in the first place when the patient comes to you. And then when you start your treatment, you can monitor over time and see how the patient is responding to the treatment that you give them. I'll be talking about some of the specialized tests that are available. I'll be talking about the benefits and the drawbacks of each, and I have no financial interests in any of these. So the first one that I'll be talking about is the Tear Lab osmolarity kit. So the TFOS Deuce 2 report is also stressed a lot now on tear film osmolarity because it's a much more objective measurement of dry eye. So somebody who has a high osmolarity value has more severe dry eye. So this is an instrument that gives you that measurement. The disadvantage and the drawback here is that the repeatability is an issue. Sometimes you do the same investigation in the same patient after some time and you'll realize that the value is a little different. So that is where for me this instrument is not up to the mark in that way. Inflammadry is another important kit which is available now. What this does is it detects MMP9 levels in tears. So this is basically telling you if there is inflammation in the eye. Based on this, you can decide if you would like to include steroids or other anti-inflammatory agents in your treatment regimen. So the drawback for this is that this is going to tell you that there is inflammation in the eye. This will not be telling you if there is inflammation in the eye because of dry eye or because of something else. It could even be VKC or maybe even an infective conjunctivitis. So that is something that you have to see and clinically decide. The other important tool that we use in our practice routinely is now the Lipiflow 2, which basically uses interferometry and visualizes the lipid layer of the tear film. In addition to that, you also get the blink dynamics and you get imaging from the Meibomian glands. So what you see here is on the left side is an individual with a very healthy looking thick lipid layer where you have a lipid layer thickness of more than 100 nanometers. On the right, what you see with this blink is an individual with a much more dull looking lipid layer, and the lipid layer thickness here is about 39 nanometers. So this is somebody with evaporative dry eye, and this is somebody that you would like to treat on looking at these interferometric images. Also, you get these images of partial blinks. What this is able to tell you is that if there is a high ratio of partial blinks, you might want to give a lubricant gel or ointment because the tears are not getting distributed too well in this particular patient. So this patient might benefit from additional lubrication or lubrication that lasts a little longer in the eye. And these are Meibomian gland images that you see. What you see on top here is an individual with relatively normal Meibomian gland. So there is some amount of tortuosity here, but otherwise not much dropouts. However, when you look at the individual below, you see there is a huge amount of dropouts of glands. So this is somebody who's likely had chronic and very long-lasting Meibomian gland dysfunction. There is also a Meibo scoring that has been proposed, depending on the degree of dropouts that exist, and you can score the eye from score 0 to score 3. And when it comes to managing Meibomian gland dysfunction, the aim of the treatment becomes to break that vicious cycle that I had spoken about. So each intervention that we take acts on different components of the vicious cycle, and some on multiple components of it. So for example, oral tetracyclines would act on the inflammation, and in addition to that, also reduce the bacterial load that exists. And steroids again would target the inflammation. Lipids would help take care of the lipid layer deficit, and lubricants and lid hygiene also act on different parts of this vicious cycle that needs to be broken for us to be able to bring back the homeostasis of the tear film. Warm compresses and manual lid expression do form the first line of the treatment, and they do play an important role. But the issue that exists with warm compression is that you are applying heat at the external surface of the lids, whereas the Meibomian glands exist closer to the inner surface of the lid. So even if you are able to maintain sufficient temperature at the external surface, you do not necessarily get that at the level of the Meibomian glands. So that is where the Lipiflow or the vector thermal pulsation system helps, because it has these cups which you place in the palpebral fissure, and the heat is applied from the inner surface of the eyelid, and you get pressure pulsations from the external surface. So it's a 12-minute cycle. You can see the pressures and the temperature slowly building up, and subsequently at the end of the procedure you get a report of the treatment having been done. So there are quite a few RCTs available as well now, which have found that vector thermal pulsation is more effective than warm compresses, both in terms of objective measurements of dry eyes as well as the symptoms of patients. A very genuine drawback here is the cost. It's a pretty expensive procedure, and you cannot really offer it to all the patients. In addition to that, if somebody has a huge amount of gland dropouts, then you really need to counsel the patient well, because the benefit that patient is going to get from Lipiflow or from any treatment for that matter is not going to be very, very significant, because there are already a huge number of glands that have been lost, and those glands don't come back. There are certain other modalities available as well that play an important role, such as these eyelid heating masks. So what you see here is a USB based heating mask, and the person sits comfortably with the controls in his hand, so he can adjust the temperature depending on what is tolerable to him. And if you look at the graph on the right side, you see that the different masks that have been shown, all of them are able to get reasonably good temperature profiles, at least at the external surface of the lids. And when you look at the red line, that is what is a face cloth. So definitely not getting the right temperatures there with the face cloth as compared to these masks. This is another instrument which is available, which is called the Meibo Thermoflow, which again provides heat from the external surface. And you do see symptomatic improvement in patients with this as well. But the limitation with both the things that I just mentioned is that you are applying heat from the external surface and not from the internal surface. So there is not much data that compares all of these modalities. There is one small study that I was able to find, and in that it is mentioned that Lipiflow is able to get better temperature profiles at the level of the Meibomian glands, but there is more literature that is needed on this. Another modality that is catching on and becoming extremely popular now is intense pulsed light, because this was originally used for rosacea and other skin conditions, and dermatologists had been using it, but it has now been found to be effective in MGD as well. So this provides bursts of light at specified areas of the skin, and it basically helps by reducing the vasculature around the Meibomian glands, which reduces inflammation and also plays a role by the heat that it provides. So that is also another factor. However, when the original publications by Toyos and the original group had come out, they had stated that this is not really known for its efficacy and safety in the pigmented population. So for us, for our population, which is primarily pigmented, we need more data to really see if it is effective in our scenario. So to conclude, Meibomian gland dysfunction is an underdiagnosed and undertreated entity, but extremely significant and extremely common, causing dry eyes in a lot of patients. There are a whole range of new diagnostic instruments that are available now, and it is really up to the practitioner to see what is more relevant in their practice. And also in terms of the cost settings, there are a whole range of treatment solutions that are available as well now. Some have been there for longer and have more literature to support their efficacy and safety, whereas some are more recent and need to be looked at a little more closely. So thank you.
Thank you, Tushar. The audience is brimming with questions. So